Welcome back to Healthcare Rounds, your insider access to the healthcare industry. I am John Marchica, CEO of Darwin Research Group and your host for Healthcare Rounds. Our guest today is Natalie Davis, CEO of United States of Care. And Natalie brings nearly 2 decades of experience shaping and implementing American healthcare policy to improve the lives of all people, and has with tenures at the Centers for Medicare and Medicaid Services and the Bipartisan Policy Center. Natalie, thank you so much. I've been wanting to talk to you for some time. I'm glad we finally pulled this together. I think your folks and our folks started talking like 6 months ago. So I'm glad that we're able to talk. So thanks for coming.
Me too. I'm so excited to be here.
Great. So I gave that little 10-second background, but I think it would be helpful for everybody to just understand a little bit more about where you've been, your background, and then, why did you start up this organization?
Yeah, great. Like I said, I'm so excited to be here. I am, as you said, Natalie Davis. I'm the co-founder and CEO of United States of Care. I live in Washington, D.C. with my husband and 4 kids. And we actually came to D.C. because I wanted to be a museum curator. I had been studying, I know, naturally right then into health policy. But I had been.
So wait.
Yeah.
From a young age, you wanted to be a museum curator, or this is something maybe in school that you wanted to do this?
Yeah, in college.
That's cool.
I was studying sociology and art history. And for me, those are both storytelling of the individual and society and how they impact each other. And so I wanted to meld sociological theory with museums, and had an internship at the American History Museum, the Smithsonian, which was amazing. And then my husband and I moved here. He went to law school, and turns out nobody leaves museum jobs unless they die. So I had to find another route, and went to actually a temp agency to get some work. And they were like, hey, you studied food deserts and anorexia and bulimia and mental health. And all of that to me was society and the individual interacting. And they said, that's health policy, or that's healthcare. I'm like, I don't know what healthcare is. And they're like, that's it. So this is a good city to do it in. And so that actually is how I ended up in healthcare. And I'm thankful for that. I still, have these daydreams about working with a museum someday, which maybe will come to life. But that's how I ended up in the healthcare space.
They say the same thing about classical musicians. Like, not that many jobs. Once you get to first chair in the orchestra or whatever, they don't leave very often. Yeah, so it's kind of like museum curation. So it's an interesting name. And I'm wondering, so I get kind of a little bit of the background, but how did you come up with the name, and what were the origins for really wanting to, and of course I have to know about the name. People ask me about Darwin Research Group all the time. They're like, what does that have to do with Darwin? And not really anything, but so what is it? Obviously what your name is much.
That's why you picked Darwin.
Evolution. At the time, I was kind of evolving as a person, that kind of thing. And plus, maybe you thought about this too, but I didn't want to name a company after myself. I just wanted something independent of that.
Yeah.
So that neat. Was the whole, evolving and all of that. So what about United States of Care?
Yeah, well, funny. My husband came up with it while we were sitting on the couch one night while we were trying to figure out what to name this nonprofit. So I started the organization with many others. Andy Slavitt was a co-founder. On our original board was Senator Frist and Rhonda Meadows, Governors Beshear and Governor Douglas, really, and many others. And then we had our Founders Council, really people coming together to, with the belief that more people need quality, accessible healthcare. We really wanted the name to evoke how united people actually are across the country when it comes to healthcare, even though, especially because we actually don't often talk about it that way. We don't often look for the places where people agree on what they want from the healthcare system, but that was one of our goals with the organization. Our mission was to be able to show that if you ask people what they need and what they want, there's similarities across demographics. We really wanted to show that united aspect. Being a policy organization, kind of wanted it to have some stature and substance, which I think United States of Care gets to. And then also that it all boils down to care and not just healthcare, but really, caring about the mission where more people need quality, affordable healthcare. There's a lot of tenets of the organization that were in place when I was at CMS, like you said, for almost a decade, working on the implementation of healthcare.gov and the Affordable Care Act, the turnaround then of healthcare.gov when it didn't launch at first. And then Andy Slavitt, when he was the administrator for CMS, I was his right hand. And really there, a couple of things, are part of how we do our work at United States of Care, which is, back then, one of my jobs with him was to create our listening tour. And we went across the country for 2 years and talked to, in different locations across the country, talked to patients and community activists and governors and entrepreneurs and venture capitalists and legislators, media, to really understand, what does healthcare look like across the country? What messages do we have as CMS for people to do better for the beneficiaries? Then we also heard messages on how CMS could be doing better for people, doing better for the care delivery system. And there I became really obsessed with this kind of idea of responsive policy. Like, how do you make sure when you put a policy out that you're getting the responses back so you can keep fixing it? And we also, in that time, especially when you didn't call it Affordable Care Act, when you didn't call it Obamacare, when you talked about, insurance and getting care and experiences that people had in their personal life and their pocketbooks, it became really clear that you couldn't really tell who they were going to vote for, what, demographic they had of income or geography, but really heard people saying the same things that they need out of healthcare. And we really wanted this to be an organization that drove really good policy, but having at the center, understanding people and using that to drive change.
Yeah, I've seen Andy Slavitt speak a couple of times. Really impressive guy. But I really got to hear him more through COVID when he was on TV a lot, and just a real straight shooter. Smart guy. One of the things I'm curious about your thought about this, which is, healthcare. It seems like forever it's been this political thing. And I get it. Policy decisions and economics, it's about scarcity, right? And trade-offs and trading off scarce resources. So I understand that. But I want to home in on what you had said a minute ago about the things that we agree on.
Yeah.
And from a healthcare perspective, it's my belief, and I haven't done any of the research on this, this is your world, it's my belief that we have a lot in common in terms of what we want out of healthcare.
Yeah.
And then you get into these policy debates, and it's like, what was it? The Clinton years? It was, was that when they were going to push somebody off the cliff? Throw grandma off the cliff, or was that Obama? I can't remember.
Yeah.
But and you're evil if you think about single, like a Medicare for all. If you're from one side of the fence, and then if you're all these things tied up in political nonsense.
Yeah.
What is it? Where do we find common ground? And what is your research? And when you were doing that tour with Andy, what is it that we can agree on? Where is the consensus?
So at United States of Care, we've engaged over 25,000 people, 5,000 hours, every demographic, and every state, and have 98 unique data sets. We're building what I call the world's first data lake of the human experience in the healthcare system. Not only where do people agree or disagree, but the emotions they have, the language they use. And so I can go into some of that. When we started this research, 5 or 6 years ago, I started it by going out literally to people's kitchen table, like a kitchen table in San Diego, a red hot and blue in Texas, on the streets of Philadelphia. And then even when the pandemic hit, we were doing Zoom calls and interviews in that way. And at the beginning, we call it authentic listening because we really wanted to see, could we just hear people first? And so we would just ask 5 questions and we would take down the answers and found themes of where do people agree on what's working and not working in the healthcare system, and what healthcare system would happen, would there be if it were meeting their needs, both health and financial. And then as we do with all of our research, we move that kind of into more scientific processes where we're actually doing focus groups so we can make sure we're, as we call it, listening loudly to certain demographics that are impacted. And then into qualitative, so like polls to put numbers behind it to say like, no, really, like across demographics, we have the data to show that these stand up. And that really does help a lot with our work with policymakers. So the places where people agree, a healthcare system that would meet their needs, there are 4 shared goals. One is people would have the certainty that they can afford their health care. And that is, we could have just said people can afford their health care, but we added the word certainty in there because it is the uncertainty that just drives people crazy. You don't know if you can afford something. And so you avoid going to health, get something done in the healthcare system. You sit up in the middle of the night worrying about that bill, that it will come or hasn't come. What will it actually cost? And so for us, it was really important to get that emotional resonance in all of the goals. So the first one, people have the certainty they can afford their health care. Number 2 is that people want dependable coverage as their life changes. So their insurance, they want it there when they need it most. And right now, people feel like it isn't there when you get pregnant or you get older or cancer or you lose your job during a health pandemic and thus lose your coverage, right? Like we have proven over and over again to people that your insurance isn't there when you need it. And so in a vision for healthcare that people want, they would have dependable coverage. Number 3 is people want personalized healthcare, which means what, when, and how. When you talk to people, they want it in their house. They want it in the community. They want more support for mental health. And so this idea of personalized, they don't use it like we do sometimes in healthcare where we mean, precision medicine that's like personalized to you, but more so like see me as an individual and let me get it in a place that where I can access it. And then the 4th goal is that people want a healthcare system that's easy to understand and navigate. And usually it's where people laugh if you're in the healthcare system, because maybe it's the hardest one to accomplish.
Good luck.
Yeah, exactly. Good luck. But there, people really talked about transparency and navigation. One woman, there's one about like the word navigator resonated with people, and they don't mean it in the Affordable Care Act way where people are helping you enroll in coverage, but more so like, hey, if I get a cancer diagnosis, can someone from the healthcare system be there with me and my spouse to take notes and make sure that I heard it all right and I'm asking the questions that I meant to and I know where to follow up because it's just so much, or helping me with insurance, or helping me put in a bill for reimbursement or something like that. So a healthcare system that meet people's needs would be easy to understand and navigate. And so across political parties, race, ethnicity, income, geography, those 4 goals resonated with people. And then we went back to the public and said, okay, here's 70 different policy solutions that would meet these needs if done well, would build a more equitable healthcare system. Which solutions would raise to the top, discuss them. And 12 became really clear that kind of fit into those 4 buckets, whether that's expanding Medicaid and CHIP, getting people tax credits if they buy off of if they're getting insurance outside of their employer, all the way that to reducing the cost of prescription drugs, supporting caregivers who care for loved ones was one that was almost at the top of all political parties as an issue to address. But same with maternal health and mental health. And then again, getting better price transparency as well as this kind of navigator buddy to help people through the system. And so those 4 goals and the 12 issues is what we call United Solutions for Care. And that is our agenda for reform that we wake up every day, making sure that we make progress towards building that healthcare system that people tell us that they want.
What did you find, or did you ask the question, among those people in their thinking about a Medicare for all or some kind of similar system? what's their perspective? And then, since you live there, and I'm not asking for the TV opinion, this is your policy circle's opinion.
Right.
What's the appetite for something like a Medicare for all on the Hill these days?
Yeah. Okay. So that's a great question. So when we started this listening work, it was very close to the summer of repeal and replace, of the Medicare for all fights. And I was very genuine going to the general public and saying, in this listening set, in this formative time where we were building our agenda for reform, like, hey, if y'all want to burn it down, like, we could be that organization. Like, you tell us, like, is that actually what you want, is a burn it down and build it back up, which, you could use to think about repeal and replace. You could use in some way to think about Medicare for all, because it would get rid of so much of our healthcare system that we have right now. And one of the really interesting findings was, and we don't actually use policy terms in these formative conversations.
Sure.
We don't.
So people probably wouldn't get it if you were all wonky with people. Yeah.
Yeah, but we also don't want to say Medicare for all, and then all of a sudden people's like political brains turn on instead of just like experiences. Yeah. So it turns out when we would use words like incremental or targeted versus like major overhaul, and have people like discuss those in focus groups and then polled also to put numbers behind it. And it's actually really interesting that there's a huge loss aversion. So while people really don't like the healthcare system, they really, really want to see changes, they can't stomach the idea of big changes. They have hacked the system so much and duct taped it together in the way that kind of meets their needs. Their pediatrician will text them at night, like mine will. You have the pharmacist who'll keep, your prescription on open and maybe stay late on Tuesday so you can go in. Your insurance kind of covers this therapy, so you do it. But the idea that people just don't trust you when you say you're going to do an overhaul. And if they believe very much so that if you do an overhaul, you won't have patients in mind. It'll be to make other people a lot of money on their back. And you actually probably won't be able to pull it off if it's so big. And so, I think there's a lot of appetite for change. And a lot of people I know very much believe in Medicare for all and believe in taking away the ACA or believe in the ACA. But the sentiment that people have and voters have across the country is like very risk averse, very high loss aversion, which is why you mentioned, during the Clinton reform or Obama reform, it's very easy then to find opposition messages that gets directly to the heart of what people worry about, which is you're going to take away what they need. You'll be able to see your doctor. No, you won't be able to see your doctor. There's going to be death panels. Like, you can get straight to the emotion of people, and very easy opposition messaging to pull really on those, like on the emotions. So that's really longer than you thought I'd give, but I love that.
No. I mean, it's an incredibly difficult challenge because, in having any kind of major, first of all, you have the straight up political. Yeah. Same reason that you don't use Medicare for all in your focus groups, right? You have this sort of knee jerk, other party, other thing. I don't like it. And then I think there are a lot of realists probably out there in DC that say a lot of people out there make money on healthcare, right? I mean, we make Darwin Research Group kind of indirectly. We study healthcare trends and, big health systems and all of that. And so, but we're making money on it. Right. I don't think that would necessarily change. We'll always find something to research and write about. Yeah. But there may be people who are threatened, their livelihoods threatened by having a single, for lack of a better term, Medicare for all.
Single payer or something. Yeah.
And it kind of leads into my next question, which is, literally like a couple hours before we started talking today, there was a Modern Healthcare headline that said something to the effect of, people aren't paying attention to healthcare in this election, or it's a secondary kind of, concern. Setting aside the women's healthcare issue, setting that aside, is that where we are? I mean, are these other things just more important? And does it make your job harder to talk about healthcare if it's not being, sort of, at least in the political season right now, not being, healthcare issues don't seem to be raised as primary concerns?
Yeah, I mean, we have felt the same thing as a healthcare advocacy organization, having talked to people across the country so much. And the number one issue is affordability. It is. If you talk to people about mental health, maternal health, rural, I mean, it doesn't matter what our entry point is. It always, the first thing goes to affordability. People either can't afford it or worried they can't. And so I think when medical debt is one of the highest debts that households have in this country, when we have hospitals closing and leaving communities, when people hear about different healthcare trends, or there's so much that happens. It's so personal and it's so costly that they aren't hearing enough from the in the elections right now. I think there is a very important conversation happening about women's reproductive health, like you mentioned.
Sure.
But left off of that is we're not talking about the kind of quote unquote kitchen table pocketbook issues that people are really facing across the country with making healthcare more affordable and accessible for everybody. So I totally agree with that poll. I was really happy to see that come out because we have felt the same way.
So, what would you say? And I had some questions about AI that I want to get to in a second. But now that you've been doing this for a few years, and then just in my mind, actually, before I ask this question, would you see yourself more of an advocacy organization rather than a lobbying organization directly?
Right. That's right.
Okay.
We see ourselves as carrying the voice of people to the halls of power in order to change all this listening information that we have and data in order to actually change the healthcare system. We do that through policy, advocating for policy reform. So
what would you say?
The lives of over 250,000, million people across this country at the federal and state level.
Yeah, I mean it's a laudable goal. So my question is, what's your biggest win so far?
Yeah.
What is the thing that you've been most proud of, a big win, policy win that you've been able to achieve, or educational win that maybe,
We are in upwards of either in 12 states or building towards being in 12 states. And it's all tackling that number one issue that we've heard from people, which is making healthcare more affordable. And so through work that we've done in Washington, in Colorado, and Maine, and Oregon, New Mexico, getting people more affordable insurance and kind of shielding them from surprise bills and high fees has been, I mean, that's people's pocketbooks. That is perhaps even building trust for them back into the healthcare system that we know is so important. And so we're really, really proud of our affordability work that we've been doing since we've started the organization.
So let's talk. One of the other thing that really caught my eye, just in doing a little research before our conversation, is your healthcare resource hub in AI. Now, obviously, I mean, I think if we looked at the last, I don't know, 4 or 5 episodes of Healthcare Rounds, AI has probably crept 10 episodes. AI has probably crept in. So obviously, it's what a lot of people are talking about. But talk to me about what is this hub all about, and then what is your organization's focus on AI, and how does that relate to your advocacy efforts?
Yeah, so we, as we look at the healthcare system that people want, as well as the future of what will be the healthcare system, we know that AI is a part of it. And so on our agenda for reform, we didn't hear from people like bring on more AI or bring on more technology, but the things that they do want: better navigation of the healthcare system, more transparent costs, perhaps more access to things like mental health and other kind of experiential needs that people have, better support for caregivers. You could see that AI could be a really powerful tool to bring people that healthcare system they want if it's done in a responsible way. And so we are very excited about AI and really want, though, the patient perspective or the voter perspective or the everyday person perspective to be a part of these conversations. AI is moving so quickly, which is amazing. But if you look at every article, if you look at every, a lot of conversations about AI, the idea of what do people actually want from AI coming into their healthcare experience is really missing from the conversation. And so us being us, we threw out a quick poll this summer to really understand, how do people think about AI entering their healthcare? What do they know about it? What do they like? What don't they like? And do they want it regulated? How do they think about this concept of regulating it specifically in AI? And so we did that poll, and I can talk more about the findings, but then we have this AI resource hub, which really is to help kind of bring definition of best-in-class definitions to different parts of AI in healthcare, because we get questions from policymakers a lot.
Sure.
And state legislative actions, federal interest in AI, and then our takeaways from the research that we did on how people think about AI in healthcare.
What were the sort of patient concerns, or what were their thoughts? And then sort of follow up to that would be, how salient is the issue? What level of knowledge did people have?
Yeah.
Because you and I reading the trade stuff on a daily basis, or the health policy stuff. It's in the news every day, but that's for us, not necessarily for the consumers out there. So what did you find?
Yeah, so we found that adults are generally unaware of the way AI, the use cases that are being used in AI in healthcare through AI, that prior to taking the survey, half or fewer were unaware of the variety of ways that AI could be used in healthcare. And then they were very divided on their feelings about AI coming in. We had people check all boxes that apply, but about in the 28% range, people both clicked concerned, uncertain, worried, but also optimism and comfortable or excited. Those were a little bit lower, but there's an opening there that I think is really interesting for the healthcare system and innovators to think through. But there are concerns and cautions. A lot more interest from people in AI being a part of more administrative tasks. So when we did use cases, people thought that recording conversations, analyzing medical data and history, communicating test results, were at a much higher, about 50% felt comfortable with that. However, there was a lot more discomfort with more complex or subjective tasks, such as determining treatment plans or diagnoses or performing surgery. And when we did ask people where they had heard most about, if they knew about it, where did they hear from it? And about 50% said from the news, not from their doctors, like news and social media. It was not from like medical experts or their provider or others that are in the healthcare field. So, I can even go into more details there, but really interesting, and a survey that we'd love to have funding for, that we could do often, to see how that changes over time. I think this is obviously going to move so quickly.
My sense is that probably in healthcare, that we're talking the general public, there's the same level of trepidation, concern, optimism as they are sort of like AI in general.
Yeah.
But as it relates to healthcare, my sense is as well, as you start having more applications of AI that are visible to the consumer,
yes,
they're probably going to, for the trust factor, they're probably going to need to have some education around that, need to understand
transparency,
all the transparency and all of that.
Yeah. Interestingly, demographic wise, Gen Zers are significantly more likely than other age groups to say that they don't want their physician to use AI. I think these are, this is where I would love to go to focus groups and talk to people, but I think Gen Zers have grown up digital natives and being educated in school about how to think about AI and online and navigate that in a way that older generations haven't been. So, I think there's a good degree of skepticism from Gen Zers. But then we saw, interestingly, Black adults are significantly more likely than other races to prefer extensive uses of AI tools in their healthcare. And again, this is where I want to go do focus groups to talk to people about, especially these Black adults, what interests them more in this, and why do we see that difference across not only the ages, because those were just guesses that I had, but also the race, different across race.
That's really surprising.
Yeah.
I mean, that's really surprising, Natalie, that the Gen Zers,
I know.
I mean, I've got 4 of them, 27, 25, 23, 20. I got those, I think I got those ages right. So I have 4. And they're the most, I don't know if the word is permissive, but I mean, they leave their privacy at the door.
Yeah.
I mean, how many of these people are on TikTok?
Right.
And are freely willing to, I mean, there's lots have been written about this and talked about this, freely willing to give up certain liberties that maybe older adults are, like myself, that might not be willing to in an online world. And then yet they're the most concerned about AI. It's like,
I think it's that. Yeah, I agree with you. And it would be really fun to talk to more folks about that. And, are they willing to do it on TikTok because there's like a social aspect to it? But then with the doctor, they know that that's fraught. I mean, it's fascinating.
Yeah. Yeah. So couple more questions and we'll wrap this up, Natalie. And one of the things I wanted to talk to you about is somebody who, worked for Andy Slavitt, who you were in the, I mean, I preceded you. So the work that I was doing in school really was in the, 2005 to 2012 sort of time frame. So a little bit before you were in CMS, I think. But the things that we were studying were the things that ultimately became, at least some of those things became part of the ACA. And I've talked about that before on this pod. But you were in the thick of it. And really, like you mentioned, the listening tour, seeing a lot of these things come to fruition. So looking back now, end of 2024, back to those days and some of the things that CMS and the CMMI was trying to implement, how would you assess where we are today? Sort of the state of value-based care. I talk about that a lot on this pod. I always ask the question around, where are we? What, from your sense, where are we? Where have we done well, and where have we not? I mean, I'm assuming that when you were at CMS, the bundles were coming into fruition, the ACOs were coming into fruition, probably second or third generation of ACOs, right? The Medicare Shared Savings Program. So where are we from your perspective today?
Yeah, it's a great question. And I think there's been a lot of progress made. And, as we continue to kind of tinker with models and, as CMS is doing right now, make sure that we are focusing on models on issues that, really matter to patients, and especially patients that are often left out of our healthcare system. We've made a lot of progress. I think our biggest kind of concern right now is that the people that were around, both the members of Congress as well as their staff, that were around when value-based care was written into the ACA, and then there's all that implementation. They've all retired. They're all gone. Not all of them, but a lot. And
most of them,
if you think about how important it has been, and it's kind of remarkable, it has stayed a bipartisan issue since that day across, 2, now 3, pretty different at times administrations. It has stayed bipartisan with bipartisan support. When we talk with members on the Hill now and their staff, they don't really, no fault of their own, they don't really understand it. It is very wonky conversations, very deep in the weeds, and really hard I would say we haven't done a good job of connecting the promise of value-based care, the work that we've done, to actual patient experiences, the 12 things that people tell us across the country that they want. Elected officials want to know, why should I take this up? And what do I tell my voters? Because when I go back home, they want to hear what I'm doing to make healthcare better for them. I don't know how to tell them I'm doing value-based care and models and risk adjustment. And
it's way over people's heads. Yeah, they're not going to.
And so in our true fashion, we have had a really cool project initiative where we have gone out to really understand, again, if you look at United Solutions for Care, our agenda for reform, the things that people want, they want better mental health, they want better navigation. They want, they don't use the word coordinated care, but they want things more seamless. They want it in the community and at home. All of that is not possible in fee-for-service. So as we think about the need to educate members in order to shore up the bipartisan support for value-based care, we said, okay, we got to stop talking about it the way we have for over a decade. We need to really understand, what does this mean to people, to patients, to voters, and then let's go educate members so that they understand it, they can champion it, and tell their voters what they're doing back home. And so we had some really fabulous, really, really cool focus groups where we didn't use the word value-based care, but we said, okay, here's this different way we do targeted changes, because it's not a big overhaul. We do targeted changes in healthcare. Here are benefits that will come about in this new model without using value-based care. But these were the promises, that we have agreed on the healthcare system that could happen, and, payment reform. And the things that rose to the top are not the things that we talk about when we talk about why value-based care is important. People want more time with their doctor. They want, it comes down to time, more time with their doctor face-to-face, less time in the waiting room, less time coordinating their medical records and retelling their medical history. They want more quality over quantity. And so there was a woman who said, and in healthcare right now, it's like a high school cafeteria, and you just walk down the line and slop healthcare on, and they move you along and slop more on, and out you go. And it's what a great analogy for fee for service. Yeah. But people really talk about they want better quality and not just this quantity game that people feel. And they also want to be seen as a full body, a full person. So whether that is their mental health is seen as the same system as their diabetes and their knee surgery, and the language that they speak, they really want to be seen as an individual. And these were all things that we say, if done well, value-based care can promise. And so those are the three that rose to the top. And then we went back and we were all right, people call this value-based care. What do you think? And it was one of the worst performing messages we've ever tried. People hate the word value.
I believe it.
Yeah. One woman was I don't buy value bacon and I don't want value healthcare. It's the cheap bottom rung of the grocery store. And we've used that now to associate with healthcare, which is the last place people want value. And they wonder who's creating that, who's deciding what value it is for me. And so, educating policymakers on this as a thing that brings value, pays physicians differently, and saves the taxpayer dollars, money, don't resonate at all with voters. In fact, actually make them mad. It's doctors would get paid better than they are now. Well, aren't they doing their job? Why should they get paid more to just do the thing they're supposed to do? Yeah. And they don't really, taxpayer dollar doesn't mean much when you yourself feel like you can't afford your health care. So we went back and said, what should we call this then? And patient first care really resonated with people because, again, they want to see themselves at the center of all of this. And so that's what we call it, patient first care. That's the education that we do with state advocates, with state policymakers, and in Congress. And we actually just published a couple of weeks ago our policy principles that if you were creating this healthcare system and the value, in a payment reform sort of situation, what are the principles that you would use to build that policy that would then have people more in the center of it and addressing the things that they actually want?
I almost think that now I'm way out of my field, but I'm speculating that when you use those terms, exactly what you said, value, they think of the bargain basement. Oh, this is all the stuff that they put out at Safeway. It's only $1. It's the value, right?
Right.
But that if you could somehow, and I don't know the right terminology, but have people thinking in the terms of the patient experience,
yes.
How you would experience a Nordstrom, or how you would experience the difference in buying, I don't know, certain types of clothes. I don't know. It may even be harder now because of the shift to online purchasing, and the way that people experience retail is very different today than it was 10 years ago or 20 years ago. So but it's really interesting to see how people might respond. I think that things like you said, paying doctors more or these kinds of things, they resonate with economists and policy people, right?
Yeah.
But not with people. And my sense is that if you talk about the principles of, let's say, a Medicare for all or something, like just in terms of the principles, everybody's on board. But then when you say the government is going to do it, they think that they're just going to screw it up.
Right.
Like it's too complicated even for the government to have one single actor.
Yeah. People certainly feel the complexity of it more than they want to, especially, but they certainly understand how, it's very, and even the word value all of a sudden also brings people back to like making money, and people like the healthcare system there's so much money in the healthcare system. So like, cause it's a word about money. So we found it to, we really need to do a better job as the healthcare system of when we talk about policy reform, using language that matters, patient first care, coordinating your care, helping your caregiver who's there with you, co-locating stuff really appealed to people. And then doing a better job of like telling success stories that not about a doc feeling better, but about a patient having a better experience. Like we don't have a lot of ways that we can show policymakers right now, like this patient really enjoyed this experience and it feels different. And so I think for the listeners, the more we can be lifting up where the things that matter most to people are occurring as we are reforming the healthcare system, that will really help the cause to make sure, value-based care really could be under threat politically if we are doing more to shore it up. And so, it's going to take all of us working together. On our website, we have another hub on patient first care, and there you can find a ton of resources, whether that's about policy, our findings, even messaging guide on how to talk to leaders and policymakers about it. So we're really hopeful that that'll help people as we, go from across the healthcare system to really shore up what we call patient first care.
Well, that leads me to my last question, which is, how do people get a hold of you? How do they find US of Care? How do they get more information? All of the above.
Great. So you can find us at unitedstatesofcare.org. On the right, there's also a donate button if you love our work. We are a fully philanthropic organization. We'd love your support. We're on all social media channels. I write personally on my LinkedIn account. Get in touch if there's ways that you want to work together. We have a newsletter that comes out about every 2 weeks, which people love, that you can sign up for.
I will be doing that.
What you think? Great. Thank you.
Well, Natalie, I want to say thanks. I appreciate your taking the time today. I love talking health policy. We could talk for another hour, another couple hours, but I think we'd lose a lot of listeners. But thank you again so much for taking the time. Really appreciate it.
Thank you.
As always, that'll do it. That's another episode of Healthcare Rounds in the Can. Our guest has been Natalie Davis, CEO of United States of Care. As always, I'm John Marchica, your host, CEO of Darwin Research Group. And listen, do us a favor. If you like what you hear, please, wherever you get your podcast, give us a rating and maybe a little message at the end of that. Thanks again, and we'll see you next round.